Systolic or diastolic. By the end of this video, you will never mix them up. For better understanding of today's video, watch my previous shorts which have covered the basics. Let us start with the murmurs of heart. What is a murmur? A heart murmur is audible vibration produced by the turbulent blood flow within the heart or great vessels. While some murmurs are innocent, which may represent a critical window into underlying structural heart disease. The definition of murmur says it is an audible vibration caused by turbulent blood flow into the heart or the great vessels. It is heard with stethoscope during auscultation. The physics behind the murmur is the turbulence that occurs due to the high velocity, narrowed orifices, that is stenosis, and retrograde flow of the blood in the incompetent wall, that is regurgitation. The significance of the murmur is represents a window into the underlying structural heart disease or the hyperdynamic changes. Let us classify the murmurs on the basis of etiology. Murmurs can be classified broadly into the functional, that is innocent, and structural murmurs. Functional or innocent murmurs, these are the benign or temporary murmurs caused by turbulent blood flow through the normal heart structures. It occurs in children and young adults. It is associated with hyperdynamic states like fever, anemia, and pregnancy, increased cardiac output, and physiological flow changes. Structural murmurs are the murmurs caused due to the abnormalities in the heart structures, like valvular stenosis, valvular regurgitation, intracardiac shunts, and other anomalies like hypertrophy and cardiomyopathy. Now let us see the 7 pillars of murmurs. Every murmur is characterized systematically using these 7 parameters, where the first parameter is timing. It defines whether the murmur is systolic, diastolic, or continuous murmur. Intensity, whether it is grade 1 to grade 6 type of murmur. Location, whether it is aortic, pulmonary, tricuspid, or mitral area murmur. Radiation, whether it is radiated to the carotids, axilla, or back. The quality of murmur, whether it is blowing, harsh, rumbling, or musical type of murmur. The pitch of murmur, the high-pitched murmurs are heard by diaphragm, and low-pitched murmurs are heard by the bell of stethoscope. And configuration, where the murmur is crescendo, decrescendo, or plateau type of murmurs. Classification of murmur, where the murmurs are broadly classified into the systolic murmurs, diastolic murmurs, and continuous murmurs. Systolic murmurs are classified into the early systolic murmurs, mid-systolic murmurs, late systolic murmurs, and pan-systolic murmurs. Diastolic murmurs are classified into the early diastolic murmur or late or the mid-diastolic murmur. Continuous type of murmurs are seen into the PDA, patent ductus arteriosus, coronary AV fistula, and renal artery stenosis. Let us learn a mnemonic or the trick to remember the murmurs. The picture showing here is showing the walls of heart, where this is the right atrium, this is the right ventricle, this is the left atrium, and this is the left ventricle. Right T-PAM, where the T means tricuspid valve, P means pulmonary valve, A means aortic valve, and M means mitral valve. Now for the systolic murmurs, the trick is write 2R on the opposite sides and 2S in between. Where the murmurs are seen, like systolic murmurs are tricuspid regurgitation, pulmonary stenosis, aortic stenosis, and mitral regurgitation. For diastolic, do opposite, write 2S on the opposite side and R in the middle, where it says tricuspid stenosis, pulmonary regurgitation, aortic regurgitation, and mitral stenosis. Let's see the systolic murmurs. Systolic murmurs are the murmurs which occur during the systole, after first heart sound, and ends before the second heart sound. The systolic murmurs are classified into 4 categories, that is the early systolic, mid-systolic, late systolic and pan-systolic. Early systolic murmurs are seen into the ventricular septal defects, acute severe MR. Late systolic murmurs are seen into mitral valve prolapse or tricuspid valve prolapse. Mid-systolic murmurs are seen into the aortic stenosis, pulmonary stenosis. Pan-systolic murmurs are seen in mitral and tricuspid regurgitation. Now let us see the systolic murmurs, the flow dynamics, where the systolic murmurs occurs between S1 and S2 are classified by their timing within systole. The systolic murmurs were the mid-systolic, pan-systolic or late systolic. Mid-systolic or the ejection murmurs where the pattern is of crescendo-decrescendo type caused by turbulent blood flow across the semilunar valves or the outflow tracts. Classic examples are aortic stenosis. Holosystolic or the pansystolic murmurs where the plateau configuration is seen through the systole, caused by retrograde flow from high pressure to the low pressure chamber. Examples are the mitral regurgitation or ventricular septal defects. Late systolic murmurs that begins after S1 peaks towards the S2, often associated with mitral valve prolapse, may preceded by mid-systolic click. Key systolic murmurs are aortic stenosis, mitral regurgitation, HOCM, and ventricular septal defects. In aortic stenosis, the murmur is harsh, crescendo-decrescendo ejection murmur, best heard at right second intercostal space, radiates to the carotid associated with slow rising carotid pulse, that is pulsus parvus e tardus. Mitral regurgitation where the murmur is holosystolic blowing type of murmur, best heard at apex, radiates to axilla, intensifies with hand grip and associated with displaced apex beat. HOCM where the mid-systolic murmur due to dynamic LV outflow obstruction decreases with squatting and increases with Valsalva maneuver, distinguishing from the aortic stenosis. Ventricular septal defects are the pansystolic harsh type of murmur at the left sternal border, often associated with palpebral thrill. Small defects produce louder murmurs due to the higher pressure gradient. Now let us see the diastolic murmurs. Always remember, diastolic murmurs are pathologic murmurs. The clinical pulse says, unlike systolic murmurs, all diastolic murmurs are pathological and warrant further investigation. They are often softer, require careful auscultation with bell of the stethoscope. The diastolic murmurs are classified into the early diastolic and mid to the late diastolic murmurs. Early diastolic murmurs are high-pitched, decrescendo pattern murmur caused by semilunar valve regurgitation. Aortic regurgitation and pulmonary regurgitation are the examples. Mid to late diastolic murmurs or the rumbles are the low-pitched murmur caused by the flow across stenotic AV valve, require bell of stethoscope and left lateral decubitus position. Examples are mitral stenosis and tricuspid stenosis. Key diastolic murmurs are aortic regurgitation, mitral stenosis, and tricuspid stenosis. Aortic regurgitation is the early diastolic decrescendo blowing murmur, best heard at left sternal border with the patient in sitting up, leaning forward with full expiration. Associated with wild pulse pressure, water hammer pulse, and pinkish sign. Mitral stenosis is the mid-diastolic rumble with the pre-systolic type of murmur, follows the opening snap after S2, best heard at apex with the bell and left lateral decubitus position. Loud S1 characters are seen. Tricuspid stenosis is the mid-diastolic rumble at the left lower sternal border, increases with inspiration, distinguishes from the mitral stenosis, associated with prominent A wave in JVP and pre-systolic hepatic pulsation. Dynamic auscultation says dynamic manuals after hemodynamics help to differentiate murmur may sound similar at rest, where we do Valsalva maneuver, squatting, Inspiration and hand grip. Valsalva maneuver decreases the venous return and intensifies HOCM, softens most other murmurs like aortic stenosis, mitral regurgitation. Exception is mitral valve prolapse. Squatting increases the venous return after load, intensifies aortic stenosis and mitral regurgitation, and softens HOCM and MVP murmur. Hand grip, where it increases after load, intensifies MR and VSD, often softens aortic stenosis and HOCM. It is a bedside maneuver. Inspiration increases right-sided filling of the heart, intensified right-sided murmur like tricuspid and pulmonary murmur. Conclusion of today's topic is that auscultation is an art and a science which helps to define the type of murmur. Remember, every diastolic murmur is always pathological type of murmur. Every systolic murmur needs context. Listen, think and diagnose the murmur. Listen systematically. Correlate with pulse and the heart sound. Palpate the carotid pulse simultaneously at the time of S1 and S2. Use dynamic maneuvers like Valsalva, squatting, hand grip, or inspiration. Synthesize the sound, timing, and physiology and diagnose the case of your murmur. Thanks for watching. If you have understood today's video, don't forget to like, share, and subscribe.